What?
The printer, flipping on the printer.
And we are live, senators.
All right, good morning. This is Senate Health and Welfare. It is Tuesday, April 18th. And what we're doing this morning is looking at bills that are in other committees or that are being passed out of other committees that have sections relevant to our jurisdiction. So rather than taking the whole bill in, we're going to spend a little bit of time on the sections of the bill that relate to our work in here. And then we can draw some conclusions. The one that's most imminent, well, the two that are most imminent. So the one from GovOps on professional regulation and also on workforce from economic development. I think we need to act pretty quickly on each of those. So David Hall, you are here. And I know that we were asked to look at sections 23 and 25, but there are a number of other sections relating to healthcare, mental health counseling, and related issues that are in our committee. So we probably should look at all of those sections.
All right.
And we have a section by section. What do you want to do? How do you go ahead and introduce
Let me
yourself?
introduce myself, David Hall, Legislative Counsel. I'm not honestly sure, I'm not sure anybody's sure what the vehicle for this is,
Yeah.
considering that it came out of House Commerce as H 484, but never left the House because it was integrated into the budget in F sections and passed as such. And now Senate Economic Development may be working on this as a freestanding bill, or maybe, I don't know. It feels like everything.
I think it
I'm
may
working on
end
is-
up in appropriations.
Yeah.
So
Along with-
it will be informing the budget, but both our committees have an interest.
It's
Yeah.
great. I think I'm gonna have about $120 million of housing spending plus $40 million of workforce spending. I feel like I'm taking over the budget. It's great. It's
Oh.
my bill.
Now
How do you like
you're
to-
on the record saying that.
Yeah.
If you can,
Forever.
Exactly.
Should I share a screen here or?
why not?
Okay.
Yeah, because we'll be able to scroll through.
And so what I think, I don't know if you all, it's on your committee page. There's this
Yep.
table that I've made that has 3 columns.
We got it.
And that might be a convenient way for us to just do the shorthand version of what
Mhm.
is in the bill. I'm gonna see if I have the Zoom link here.
I just resent it for you, David.
Oh, great, thank you very much. The voice of Alexander's coming in through the ether. So 2 seconds. I feel like this is for a Senate committee. You guys doing the screen and everything. This is big time stuff.
We're high tech.
You are heavy high tech.
Yeah.
All right, so there's that. And it's up now, I think. Yes, excellent. All right. So the layout reflects what I just said in the intro about where these things lie. So that left, I guess there's 4 columns. That leftmost for the section number is where it appeared in the House version of the budget. The subject is just a general description of what's, the subject matter of each provision. The H 494 House budget language tells you basically where it is and how much it is and what's happening. And then the analog to the House version of the bill is on the far right. So if I'm in health and welfare.
So it goes down a ways and it's section 21, I think, if it starts it.
Looks like
Or-
F14.
Oh, I was in the other bill. F14, good.
I think
Yeah.
that is a great place to start. So
Sounds
page
good to me.
6 of that table.
Here's when you go through it with us, can you do this, please? Indicating the money, what it's for, obviously, and that's here, but then, is there any pass-through of this money to another organization? Or is it fully administered by the organization that's here?
Sure.
Yeah, that would be helpful.
Well, so you may remember from last year's Act 183, the workforce bill set up this series of forgivable loan incentive programs for various positions, and a lot of those were healthcare related. This is basically more of that happening in this bill. So for instance, in F14, it's the same construct. It's another VSAC program. It's a forgivable loan incentive. It's basically a 1-for-1. You get 1 year of loan forgiveness for each year of committed service. It's applicable to a student who agrees to work in Vermont. You don't have to go to school here. You don't have to go through one of our programs necessarily. So the commitment again is to serve in the state, and that's what triggers the forgiveness. F14, which was section 22 in the House version, is for the psychiatric mental health NP forgivable loan incentive program. And it's $1 million general fund appropriation. And this began life as a proposal to try to stand up a new program or reinstate an old program at UVM's NP school. And then they decided, it's not really necessary to create a new program from whole cloth. Norwich has an online program. There are other schools that have this. So essentially, it's just the incentive mechanism specifically for students. It's for current NPs to take the next level of training and then qualify as a psychiatric nurse practitioner. So that's the long and short of that one. Any questions?
No, this is fine. And I know that there are reports back on some of these things, but I think we'll hold off on that and just listen to what's here.
Okay.
Can I ask one question?
Of course.
So I remember last year, Madam Chair, when we did all these various loan programs, there was this conversation about which stuff VSAC should have and which stuff the AHECs should have.
We're gonna get to that.
And did that conversation happen at all?
At this point, it's just using that same paradigm for the VSAC administered. And
Okay.
some of them say, like working with Department of Health, but really VSAC is the administrator here, so
And VSAC has said they can do this and,
as far as I know.
okay.
Yeah, different.
That was the thing last year, is that there were some things that VSAC was like, we don't really do this.
We took we separated the AHEC. That happened during the conference committee. And
Right,
we separated out AHEC because they have so much more experience with some of the loan forgiveness programs and repayment programs.
yeah,
So we do, and I have been in communication with, as has, anyway, we've been in communication with AHEC about how this is all.
I think it was the scholarship programs that AHEC had more, and VSAC was more loan forgiveness.
No,
Or
Just,
is it the opposite? Okay.
it's okay, we'll sort it out.
So the next piece, the next row down, EMS training. So this was a separate section in the House bill, but for the Commerce bill, but for the budget, it ended up in section B 1101 F2. You'll see that subdivision F2. So there's $1 million in general funds just to the Department of Health to provide EMS training. There's not a lot of additional language really that goes along with that. It's just another $1 million for EMS.
Okay, yeah, that one, just leave it.
So page 7, the Vermont Nursing Forgivable Loan Incentive Program appropriation. So this is one of those programs that you set up last year in 18 VSA section 34. This one's specific to nursing. It is $3 million total, and it's included in section B301. So that's Department of Health's base funding. But it's got the multiple streams here. You'll see the breakdown of GF versus federal. It's all $3 million global commitment. And I leave, that's as far as I can take you down the path of what qualifies for global commitment and whether that's the right use of money, blah, blah, blah. That's not terribly familiar with.
Okay. And this goes through the Department of Health as well, through the Agency of Human Services, and that is through the workforce, the Director of Workforce in the Agency of Human Services.
That's the next one down.
Okay,
I was still on the nursing forgiveness
Okay.
program, but the next one is $170,000 general fund to pay for, another
that's the-
year of
right.
that 3-year position.
yes, so then the healthcare workforce coordinator in AHS, then going back up to section 25, then is that where the distribution of those funds is taking place? We don't know. We'll find out.
25 is just another $3 million for loan forgiveness for the nursing program
Right,
through VSAC. What was Commerce's 26 is the additional $170,000 for that coordinator position. You all had authorized a 3-year limited service position, so this would fund year 2 of that.
right. Okay, and if you look at the dollars for global commitment and general fund, it all flows through AHS. Okay. Yeah, has to. So that's good.
All right. We can go on to page 8, to F15. So this is a little bit going on here. Last year you had devoted some ARPA dollars to the designated specialized service agencies for master's level, loan forgiveness, tuition assistance. There was some discussion of, because that money had not yet gone out yet, about whether to modify that, to increase that, et cetera. What the House ended up doing is leaving that alone. So that program language stayed the same, those dollars stayed the same, those dollars should be flowing out imminently if they haven't already at this point.
There's no increase to fourth.
Well, so this is new. So we're leaving that in the past. We're creating a new pot of money from the general fund, not from ARPA, but from general funds for the designated and specialized service agencies. And this is 1 year of forgiveness for 1 year of service. And it applies across the board to all full-time equivalent staff at these agencies. So you don't have to be pursuing some sort of, master's or above.
So this is a change from the Act 183 appropriation for this incentive or loans.
It's not a change. So the 183 money and the 183 program language stays the same.
Okay,
This is new. It's an expansion. Again, it applies, it's the same mechanism.
but the difference is the expansion to anyone working within the agency of human services. That was really my question.
Yes, yeah,
So, okay.
right. So it is across the board available. And the distribution mechanism is the same. So it's just a ratio of,
Got it.
your full-time equivalent staff relative to the total.
Mhm.
This left Commerce with 4 million, but passed the budget with 3 million. So that's where they
Okay.
landed in B1101.
Okay,
Okay. F16 creates yet another forgivable loan incentive program, this one for dental hygienists. And it's same basis, administered by VSAC, 1-to-1. This actually was added at the House Appropriations stage, created of whole cloth. The appropriation you'll see is 43,480 for dental hygienists. All right, that could be, is that all for healthcare? We can talk
Dolly,
about other
that's
things
it?
if you want to talk about brownfields, small businesses.
no, only if we're building something like a recovery facility. No, I think that's it. So overall, the funding process, I'm thinking of how the money flows to the recipient has been held constant, is the same as it was in Act 183. But I'm not seeing anything in here about AHEC, and I have received information, and I'm looking at David Englander about the DOH pass-through of money to AHEC. Have any comments on how that's going? No.
I don't have any, for the record, David, I don't have any comments on that specific question at the moment.
Is there a way that we could get comments from the Department of Health regarding that?
Sure, yeah.
Because I know AHEC's experience with loan repayment is significant, and I've heard some concerns from them about how that the money isn't moving as with alacrity, shall we say. So if you could get us some information on how that's going, that would be helpful. And then I know that we'll be hearing from AHEC more than likely in appropriations, but it would be helpful to know from your perspective what's going on.
Happy to do that.
Okay, good. All right. Questions committee. So are there, I guess the question for us is the continuation, does the continuation of the work that we started last year in Act 183, does this support the workforce that we need going forward this year in the bill?
Is it a question to us, or
Yeah.
are we going to receive testimony to
No,
answer that question?
this is it. This is hard. I mean, we have heard about the need for workforce. I'm looking at Vermont Care Partners. Do you want to make a comment?
Sure, Julie Test, Vermont Care Partners. We received 1.5 million, not in 183, we have not seen those monies yet, but previous to that, we had received funds, and we had 5 quarters so far of distributing the funds. We have a 94% retention rate, while our regular retention rate is only 63%.
Wow.
So it made a tremendous difference. We used the format developed by Vermont Student Assistance Corporation, VSAC, and it worked really well. It took a really long time to get the money, and then for us to set up the program, VSAC helped us, and we're really excited. Many of the agencies have used up the funds, so we're waiting for that next pot, and we're excited about these new funds, but we also, the original funds came from the Department of Health to Vermont Care Partners to administer, which we do for free as a member service to our member agencies. The second pot, the Agency of Human Services, the 183 funds, they think those funds are, that they need to have a contract with each individual designated agency and are concerned about the amount of administrative work. So we were talking to them about this, if we can get new funds, how could those be administered? They would prefer they went to BSAC. We met with BSAC last week, and Marilyn Cargill said, you have outstanding results. If it came to us, she'll check, but if she feels like it's a fair amount of burden, they would probably want to charge an administrative cost. She says, you're using our model and you're doing it great. I don't see why you would change it. We have the same contract with the Department of Health where on a quarterly basis, we tell them what was spent. They cut Vermont Care Partners a check, and then we cut checks each individual agency. We make sure we have their promissory notes and all their files before we do that. So she thought we should keep going, but it's still kind of an unanswered thing at the Agency of Human Services. And I know the budget bill is going to be done this week here in the Senate. So I'm concerned about that. We also found out that each agency did not spend it based on their full-time equivalents. Pathway for Housing is a peer-based model. Education is not emphasized for their staff. So they've had one staff who's done tuition assistance. And then others of our agencies have used up the money and want more. And the Department of Health actually gave us permission to pull the funds at the end of this first grant, which ends in a few months, so that it's a first come, first serve for anyone who's eligible for the program. And that seems like it's a better approach. And that's what we've learned, you know, a new program, you learn things. So we would love to be able to have Vermont Care Partners continue to administer it, keep a pool, and all people who work in the agencies would be eligible, and each agency would advertise and do the promissory notes and make sure the person stays and do all that part of the work. So we're excited. It's really made a difference. We just need to work out these details very quickly.
Well, so I do know that this is gonna be, in appropriations, and some of this is gonna be perhaps determined there. But what I would ask of you is some written testimony that we could have that would help us as we look at this going forward. We need to get some response to the information to economic development tomorrow morning.
Okay,
It doesn't have to be in writing. I'm gonna go in and just talk about
I'm
it.
fine.
but
I'm
it would be
actually
helpful.
reworking the language right now.
Yeah, that would be terrific. This is one of those places where it actually does look like making sausage. So, thank you for your comments. And I know I have seen a memo from, the Secretary of AHS regarding some of this, so. Any other questions that we can't answer? Or we can?
About all of this?
About what we're looking at right here. I do have one question actually, and I'm gonna bring it up for us as, I think, well, we've got education people here. One of the areas of need in our state is in the long-term care environment and other areas where we need LPNs. And I know there was a long conversation about our tech programs and certifying people and also getting folks out who can do some of the really basic care for patients. And there's nothing in here about that. And I'm gonna bring that up with economic development, and I don't know whether education is talking about this or not.
I haven't seen it on the agenda
Okay,
for the committee.
all right, try and sort that out. Go ahead.
I would just, it seems to me like all of these things are good and we want to do them. I don't know about the specific amounts, you know, and how they determine the amounts. But without more information to dig into, I don't know that they're right or wrong. There are just so many needs. You know, there are other things we could spend money on too, in terms of healthcare, workforce development. So I'm not exactly sure why they chose well, some of them are obvious, but you know, chose these over other things, but I don't have enough information to say yay or nay. I mean, to say
Right.
no,
Right.
I'm fine with them basically, but
Good.
you
I
know,
mean, it
without
does-
digging into them
yeah.
a lot more.
You're right. The point is that it does replicate what we did last year. We're seeing good results. And so let's reinforce that. And then as time goes on, we'll find that our workforce needs are being met in a greater way. We've also had some compact work that we're doing for nurses, and maybe that'll have an effect. So it's so difficult. It's all in flux. But these are good things. Yeah, I agree.
But I would echo Senator Hardy's point. It's all good, but I'm just not sure it's proper focus. You know, why this versus that, you know, who's eligible, how many benefit, just, I know, I sense it's just a leap of good faith. But I'm a little surprised, you know, procedurally, that
Yeah.
there's no time given to actually determine, you know, group A versus B versus C.
So one of the things to consider is this, that last year was really the first big investment in this workforce. And we started out with a sort of the class of people. So you entered the class for mental health counseling, or you entered the class for nursing, and you're receiving this benefit and you're committing to a year of work for every year that you get the benefit. And so this is your first year. So now we're talking about continuing it for another year. And it may well be that it's that sort of longevity or the continuation for the time that the person is studying or the time that the person has the outstanding loan that will keep the person in the workforce and in Vermont. So I think this is the next step in reinforcing the work that we started last year. I'm not, if we have more money, then we can decide, let's put it somewhere else.
Just kind of echoing what Julie said, I
Sure.
think, because I don't know what I don't know, but we should be reinforcing success. Somebody took the money and used it properly. And if there's agencies out there that didn't use it, it should go to where it's needed and properly used, I think.
That's a very good point.
And we don't know, we don't have those results.
Yeah.
Just one thing I would say is just to build, to follow up on our exchange sort of. We did get a lot of testimony on this last year. We just haven't gotten a lot this year. And it does build on like the shortage of nurses just across the board. We just don't have enough of any kind of nurses. And then supporting workforce in our designated and social SSAs. Like,
Specialized services.
thank you. I was like,
Special services.
SSAs, what are those? And EMS, former Senator Jeanette White, if you're listening, I'm sure she's cheering that we're doing that because that was a big thing that we didn't fund much of last year and at the end had a little battle about it. So it's nice to get them some funding because EMS services are really struggling around the state. And then the psychiatric nurses, I think the NPs, we just don't have enough workforce in our psychiatric facilities in general. So it all makes sense to me. It's just, not knowing what other asks may be out there and everything is, it does build on what we did last year. So.
And the other issue that we're concerned about, of course, is a lot of what happened last time was federal dollars. And now we're trying to continue as much as we can with state dollars and whatever residual we have with federal dollars. So you'll see, for example, on I just went past where I wanted to be. Well, you'll see the GF, general fund. So this is where the Appropriations Committee will be balancing some of the needs that we're looking at. But all of the work that we're doing, for example, a Vermont Psychiatric Mental Health Nurse Practitioner, Forgivable Loan Incentive Program, F14, that money is now general fund money, where before it was ARPA or federal dollars. So that's a consideration that we're trying to continue as much as we can where we're seeing a benefit and not dropping the ball. Not easy. Okay, so,
Can I,
yeah.
sorry, can I ask one question about the brownfields? Is that,
Oh, gosh, that's
No?
totally out of our jurisdiction, but go ahead.
okay. No, I can ask it of the appropriate jurisdiction.
Yeah,
Yeah,
so, yeah, you can ask it.
economic development and housing.
That's one place, yes.
Okay.
Yeah, it's good. Okay, so what I'm hearing us all say is we don't have all of the information back from the benefit of Act 183, but we do have some of that information back, in particular from Vermont Care Partners, about the benefit and the retention of 94% versus 66%. Sounds great. And that there are other areas that we have invested in, and I think we know that we need to have a continuation of those investments to ensure that workforce continues to be available in our state. So that's really, I guess, the message. Then there are the details about administration that both economic development and appropriations will be looking at. But in terms of the healthcare world, I think continuing this will really benefit us, our state, and the workers who are out there. Okay. Anything else? I think we're good. Well, at least we have that's here. And David, thank you for making yourself available.
Sure, my pleasure.
All right, so now we're gonna jump to the next bill. Which is 5, and Tim Devlin is here, and David Engelbert is here, and Chair of Ops is here. Tim, do you want to come up? Thanks. And we have this bill as well. You want to share screen?
Let's see.
And Lauren Lehman is here. Thank you, Lauren, for being here.
Thank you.
See, I apologize, Madam Chair, I'm not logged into Zoom right now, but I think it'd be probably okay if I, well, would it be okay if I directed the committee members to just pull up on the screen, both documents are online here, I can just
We've got
direct you to where?
the bill, and then we have the amendment.
Yes, those are the two.
Which one would you like us to look at first?
So I see on the agenda we'll be kind of concentrating on sections 4 and then 7, 8, 9.
Mhm.
So 4 is in the House bill as passed. It is not subject to the amendment that the Government Operations Committee passed the other day. So perhaps we'll start with the bill as passed, section 4,
Okay,
and that is on page 7 of that bill. The first part, this part of the bill pertains to dental hygienists. Section 4 will modify section Title 26 VSA, section 642. And to kind of orient everybody here as to where this is statutorily, this is in Title 26 of the Professions and Occupations, Chapter 12, which deals with dentists, dental therapists, dental hygienists, and dental assistants. And this is let's see. Just the gist of it, this is actually section 4 and 5 also relates to the real meat of the amendment is in section 4. And this will allow dental hygienists to use the silver modified atraumatic restorative technique titled SMART in acronym form. Here, and you can see we have a correction to some terminology on line 11, changing guidelines to rules. Really, the substance is in a new subsection D, which simply states the public health hygienist who has completed training approved by the Vermont Department of Health in the SMART technique may use SMART to treat patients in a manner consistent with rules adopted by the board. And just quickly, I'll mention that the subsequent section 5 has to deal with the implementation and will not allow those dental hygienists to practice this until the Board of Dental Examiners adopts rules governing the procedure.
okay, so it doesn't really expand the scope of practice. It allows them to practice within the SMART program education I'm looking at. David Engelbert.
Now, it does, Chair, it doesn't.
Well, it does to the SMART.
Yes.
Yes, that's what I said, right, okay. It expands the scope of practice to the extent that they are also trained under the SMART technique. So they're allowed to treat the patients once they've completed that training. And I want to say something.
All I'll say is we took testimony on this in
Yeah.
health or in GovOps. This, in my understanding, and David can correct me if I'm wrong, is that this proposal came from the Department of Health in the House, saying that this would help expand access to dental care for kids. And, you know, the House, this is the House's language. We didn't make any changes in GovOps, but we heard testimony. The scope would be expanded, but it would be under the rules of the, Board of Dental Practice.
Right.
And so they would still have control over it. But there are a lot of areas in the state where we have very little access to dental care. And I think you provided a map on, I was just looking at the map. So this would give kids access to dental care that they don't have currently, and that would be helpful.
Okay,
So.
all right. Lauren, I'm looking at you, and if you'd like to weigh in at any point, just raise your hand. That would be helpful.
Thanks.
All right, go ahead, Tim.
Okay, so the next part of the bill, section 7 through 9, pertains to, let's see, pharmacists. and
What page are you
pharmacists in
on?
general.
Please.
Page
Oh,
8,
sorry.
8 of 13.
Yes, and here's where I will kind of flip us over to the amendment from Senate GovOps, just because it's really strike all for these sections.
Okay, so if we go to the amendment, that's a better idea.
And the amendment will refer to section 7 right in the first page, starting at line 7. And my notes. So here, and just I'll give a quick overview of what these 3 sections will do. They'll really permit subcutaneous self-administered hormonal contraceptions to be administered by pharmacy technicians. This is the depot shot. They also permit pharmacists to continue to administer other vaccinations, including this for COVID-19, with some additional detail as to age being a factor in the administering of those immunizations, as well as this will permit pharmacy managers to no longer have to wait a year after obtaining a license to operate a pharmacy in Vermont. And I can go into those some more details to go through here. The first instance of amendment will, as I said before, alter section 7, which will amend Title 26 VSA, section 2022 by striking subdivision 14. And this is where we have reference to pharmacy technician, as you'll see being defined here, really adding qualifier that individual must, who only while assisting and under the supervision of a licensed pharmacist shall perform tasks relative to dispensing prescription drugs, administering immunizations, and performing tests for COVID-19. Pharmacy technicians shall administer immunizations and perform tests for COVID-19 in compliance and accordance with section 2042A of this title. And here I just want to note that section 7 also has one other amendment to subsection 21 regarding self-administered hormonal contraceptions, and that's in not being amended here, but it's in the bill as passed by the House. And that inserts one word that is subcutaneous to the definition of self-administered hormonal contraceptive.
Okay, so that's section 8.
That would be section 7. Adding
Section 8, clinical pharmacy prescribing, and then it goes down.
It's right above that.
yes.
Got it. Okay.
And just want to note that that's something that the Senate GovOps did not amend from the bill as passed from the House.
Okay.
The second instance of amendment replaces section 8 in entirety. And let's see. This will be amending Title 26 VSA section 2023, which is titled clinical pharmacy, semicolon prescribing, really subsection B, subdivision 2 of that, state protocol, subdivision A, and then adds and modifies some of the subdivisions found within there. For context, I'll start on line 3 of page 2, reading subdivision A under state protocol. A pharmacist may prescribe, order, or administer in a manner consistent with valid state protocols that are approved by the Commissioner of Health after consultation with the Director of Professional Regulation, the board, and the ability for public comment. Skip a few subdivisions down to Roman 5. Self-administered hormonal contraceptions, in language, including subcutaneous depot medroxyprogesterone acetate. And we skip down to Romanet 7, which will now read, for patients 18 years of age or older, vaccinations recommended by the Centers for Disease Control and Prevention's Advisory Committee on Immunization Practices, or ACIP, and administered consistently with the ACIP-approved immunization schedules as may be amended from time to time. New section language for Romanet 8, for patients 5 years or older, influenza vaccine, COVID-19 vaccine, and subsequent formulations or combination products thereof. This Romanet language, 9, is actually the same, we just renumbered it. And I can skip over that to the new language found in Romanet 11, and we're now on page 3, line 5. And tests for COVID-19 for individuals by entities holding a certificate of waiver pursuant to the clinical laboratory amendments of 1988. Skip the citation right there. If a test for COVID-19 prescribed, ordered, or administered by a pharmacist in accordance with this section and the resulting state protocol incidentally detects influenza or human respiratory syncytial virus or RSV, a pharmacist shall advise the individual tested that the results indicate for influenza or human RSV infection and recommend to the individual to seek further care from an appropriate healthcare provider. And then the rest of the section is omitted after that. There being no further changes to that section.
Okay, questions there? Okay, just, it's an expansion access. Yeah, okay.
The third instance of amendment is looking at page 3, line 14. This will be, again, a strike all of section 9 in particular, which will amend Title 26 VSA section 2042A, just titled Pharmacy Technicians, semicolon, qualification for registration. This will add new subsections, in particular B, turning to page 4 now. New subsection B reads, pharmacy technicians administering immunizations shall meet the following requirements. 1, hold a registration as a pharmacy technician in accordance with subsection A of this section. 2, hold a current CPR certification. 3, have successfully completed accreditation council or pharmacy education accredited training program approved by the board. And 4, successfully complete 2 hours of immunization related continuing education approved by the accreditation council for pharmacy education every 2-year licensing period. Subsection C is also new. It reads, pharmacy technicians shall only administer immunizations, 1, to patients 18 years of age or older, as established in subdivision 2023B2A Roman 7, and the resulting state protocol. 2, to patients 5 years of age or older, influenza vaccine, COVID-19 vaccine, subsequent formulations or combination products thereof, in accordance with subdivision 23B2A Roman I and the resulting state protocol. I should just note here that those statutory cross references were in the prior section. There were a couple of those. 3, pursuant to the schedules and recommendations of the advisory committee on immunization practices, recommendations for the administration of immunizations, as those recommendations may be updated from time to time. 4, when a licensed pharmacist who is trained to immunize is present and able to assist with the immunization as needed. New subsection D reads, and I'm now on page 5, line 5. Pharmacy technicians shall administer only those immunizations that, 1, are recommended by the Centers of Disease Control and Prevention's Advisory Committee on Immunization Practices, ACIP, and 2, licensed pharmacists that are permitted to administer under the state clinical pharmacy protocol as established in subdivision 23B2 of this title. The new subsection E is added on line 18 here. Pharmacy technicians performing COVID-19 tests shall do so only, 1, when a licensed pharmacist who is trained to perform COVID-19 tests is present and able to assist with the test as needed. 2, in accordance with the state protocol adopted under subdivision 2023D2A, Roman 10 of this title. And 3, in accordance with the rules adopted by the board. And the last and final new subsection added here is on line 7, subsection F, which reads, the board may adopt rules regarding the administration of immunization and performance of COVID-19 tests by pharmacy technicians. And that concludes the amendments to the section.
Is a pharmacy tech is restricted from administering the test unless there's a licensed pharmacist in their presence? Is that
I believe that's the case.
Right, that's what it says. I just want to make sure that's what it meant, because
Yep.
it seems to kind of constrict the availability of testing in a significant way. Was that intentional or?
I'm looking at Lauren Lehman. Lauren, would you like to comment on that?
Sure. Yeah, that's consistent with, it doesn't need to be like looking over their shoulder, but present in the facility. It's consistent what's currently happening. And I think it's when an individual goes and seeks professionals testing. So we're not talking just about the rapid test, we're talking about other tests.
It's a different, it's not the neighbor. Okay. All right, thank you, Lauren. So, so this is consistent with current practice, what we're hearing, but just to ensure that there is a registered pharmacist in the facility. Doesn't have to be right there looking over the shoulder, but available should that she or he be needed. Okay.
And take and read the results of the test.
Right.
I'm happy
Yeah,
to talk about the test in a moment if that's.
Can you do that?
Yeah. Would you like me to do so now or after Tim is finished?
Just hold that thought. Tim, how are we doing? I think we've been through it all.
That's correct.
Okay, questions for Tim on the language we have before us? Okay, thank you. Thanks for being here. Okay, Lauren, why don't you share with us the testing protocol information?
Certainly. So the testing protocol we've talked with the pharmacies, the pharmacists, the associations, and it's consistent with what's being done right now or was done under the PrEP Act, which is that federal act that was issued under the public health emergency on the national level that in some ways preempted state licensing requirements and allowed pharmacists and pharmacy technicians, as well as other providers, to administer vaccines and to test for COVID-19. So this reflects a similar process. We heard from pharmacies and pharmacists during testimony that the COVID test administered by the pharmacies have, I'm not sure, I don't want to speak, I don't know if they're PCR or if they're rapid tests, but they come on a cartridge where you take the sample and you put it on one cartridge, and that cartridge then provides results for COVID, and sometimes also, and most often now, also tests for flu and RSV, because those present with similar symptoms. And so incidental to testing for COVID, you might get a positive result for flu, or you might get a positive result for RSV. And that's reflected in this language that if that should come up, that the pharmacist or the pharmacy tech can advise the patient, yes, you've tested positive for flu, you may want to follow up with your primary care provider or somebody else. The reason we do have some limitations on this, it is a scope expansion. So from previous Vermont law, so pharmacy techs prior to COVID did not do testing or immunization provisions, but they would be authorized to do this. We've seen over the last couple of years that that's been safe and consistent. It's not just reading, so and providing testing results. And so for that reason, we do limit it. If you're going to go to a pharmacist, you're seeking special results beyond what you get at home. You're being advised by the pharmacy tech, yes, you've tested positive, and then you refer to a provider.
Okay, questions for Lauren? So we're good. We're good? Thank you. David, did you want to add anything from the Department of Health's perspective on these sections?
Just to say that the department's strongly supports
Okay.
what's in the bill.
it feels like it's adding access, it's lessons learned as a result of COVID, and we're moving forward similar to what we did with the flexibility language in our previous bill. Okay. Committee so think about this one, and is there anyone who would have would be against supporting this on the floor? We won't be giving specific testimony, but I'll just be standing up and say yay or nay.
Sounds good.
Sound good? Okay, good. All right, so let's move on to cannabis. And Bryn Hare is here, and Michelle Childs is here. Thank you both. So Michelle, why don't we start with you?
Okay,
I
so,
can find the bill.
yeah, so for the record, Michelle Childs, Office of Legislative Counsel, and my understanding is you're just going over section 13 of H
I think it
270.
was 13, right? This is H 270, and
Yep.
we're looking at the sections within our jurisdiction. Yeah, so I think it wasn't 13 and 14. I'm trying to remember. I read it over the weekend. Let me see. Do you know what page section 13 is on? There she is. Perfect.
Yes, you're going to be on page 13.
All right, 13 on 13.
And so I'm going to go through this with this language with you. And I also took the liberty of drafting an amendment for you, just with some language that's been suggested by AHS, as well as a suggestion from the board. And you can obviously, it's your choice whether to accept them or not. But I thought, just in terms of we're in the final weeks and moving things along, I thought I'd put the language down in an amendment for you to take a look at.
Okay.
So section 13, we're working in Title VII in the cannabis chapters, and we're working for your purposes, specifically at looking at the medical cannabis registry and the chapter that regulates dispensaries that provide cannabis to registered patients and caregivers. So the First Amendment, looking at section 951, is an amendment to the definition. So just as a refresher for those of you who are already familiar with the program, and for those of you who are new to this issue, we've had a medical cannabis registry since 2004. The way that it works is that someone who is interested in being on the registry would see their healthcare provider who they have a relationship with, and the healthcare provider could attest on a form that's provided by the CCB that the patient has a qualifying medical condition. The healthcare provider is not prescribing cannabis. They're not necessarily recommending cannabis. They're just attesting to the fact that this person is a patient of theirs and that they have a qualifying medical condition as provided in statute. And so you'll see the language there on subdivision 8 of the types of qualifying medical conditions. And you'll see that in subdivision A8B, currently post-traumatic stress disorder is considered a qualifying medical condition. But in addition to the attestation of the healthcare provider, the applicant also has to be undergoing psychotherapy or counseling with a licensed mental health provider. And so this language has been struck, and you'll see the new language where post-traumatic stress disorder has been added up to line 13 to just have the same criteria as all the other qualifying conditions. And so what that amendment does is it eliminates that second requirement for PTSD, that the person be actively involved in counseling at the time. And I know you're going to hear from Bryn afterwards, so she can talk to you about why the board requested this change. So I'm going to move down to the next section, page. I'm sorry.
And there's the physician, the treating physician is stating what about the patient?
Simply that they have been diagnosed with PTSD.
And is there any qualification for the physician who is qualified, who is making that diagnosis? Because we have a long list here of things that frequently require a specialist determination. So is there a requirement anywhere in the underlying program that it be done, the physician one who treats patients with these disorders?
No, there's no requirement that it be a specific type of physician. The underlying law provides for that you have an established patient healthcare provider relationship. So it could be a physician, it could be a physician's assistant, it could be an RN. Or a naturopath.
Okay.
So page 14, on section 952, amending the registry section. So currently, if the limit for cultivating cannabis as either a medical patient or someone who's registered as a caregiver for the patient with the CCB, it allows them to grow not more than 2 mature and 7 immature cannabis plants. So this has been the plant limit as long as we have had the ability for patients to be able to grow their own cannabis. And then you'll recall a few years ago, Vermont legalized cultivation of cannabis for folks who are 21 years of age and older who are not patients. So anyone can currently grow cannabis as long as they're 21 years of age. And that limit is 2 mature plants and 4 immature plants. So when the legislature adopted that limit for folks who are not on the registry, they didn't change anything on the patient's registry. So the numbers are pretty much, as you can see, the same. The only difference under current law is that patients and caregivers can have 3 additional immature plants than you or I or somebody who's not on the medical cannabis registry. And this is changing that cultivation limit from 2 mature to 6 mature and 7 immature to 12 immature. And again, I can go into the reasons, but I'll let Bryn explain to you as to their reasoning for this, requesting this change. The next change is on section 954 for caregivers. As I mentioned, you can have someone who registers with the CCB as your caregiver, and that person can either cultivate the cannabis on your behalf as a registered patient. They could also go and pick up your medication at the dispensary for you, those types of things. And you'll see at the top of page 15, currently what's required is that a caregiver to be listed on the registry has to go through a fingerprint supported national criminal background check. And that is being changed to a name and date of birth Vermont criminal conviction record. So they wouldn't have to go and get fingerprinted and have the national check. But then it's also requiring that the CCB check both the child protection registry that is maintained by DCF and the vulnerable adult protection registry that's maintained by Dale. There's a provision here at the ends starting on line 10, going through line 14 about DCF and Dale adopting rules governing the process for releasing the information from the registry. And I'll show you on the amendment I have from you that came from AHS asking that you strike that last language and then just adding it to where they have language currently in Title 33 around who is entitled to receive records pursuant to statute. So page 16, subsection D, currently caregivers can only serve 1 patient. And this is changing it to allow a caregiver to provide for 2 patients. So if they have a special talent for growing and know how to do that, they can provide for 2 patients instead of just 1. And then you'll see on subdivision D2 on line 7 and 8, there are some patients who are minors who are on the registry, and they are currently allowed to have up to 2 caregivers. And this is adding new language that the board can use its discretion to allow additional caregivers if they feel is that it is appropriate. And that's to address, you know, a situation where a child might be living, you know, with mom and stepdad in one home and dad in another household. So still on page 16 on section 955 on registration fees. So currently everyone who's on the registry has to do a renewal every year and pay a fee. And this is changing it so that only patients with the qualifying medical condition of chronic pain and their caregivers would have to do the annual renewal. And everyone else that's on the registry would only have to do it every 5 years. And so the idea being that is if you have been diagnosed with MS, that's not changing, and therefore you don't need to constantly be getting that new renewal form and doing that every year.
Okay.
So page 17, this isn't a change to just the rulemaking, and there's language here at the top of page 17 about no rule shall be more restrictive than any rule adopted by DPS pursuant to the old medical cannabis statutes, which have been repealed. And so we're striking that. And also that was initially put in 2020 by the General Assembly to make sure that they would be able to kind of have true up the adult use and the medical program, so that you didn't have kind of more restrictive rules in the medical program than you would in the adult use once you switch to allow everybody to be able to obtain cannabis legally. And again, in the amendment, I'll show you, there's another piece of that is in the dispensary rules that you would just need to make as well. I just missed that one when we were doing the initial bill. Section 14, you mentioned, and I'll just say what that is. I didn't think that this was something that you guys were considering, but this is just clarifying that if you are a cannabis establishment and you are which is an adult use store, or if you are a dispensary that's registered with the CCB to provide for patients and caregivers, and you also sell, in addition to cannabis, you sell a pipe for smoking cannabis or any kind of that paraphernalia. As long as you're already regulated by CCB, you don't have to then go and get a tobacco license from DOL.
Okay,
Any questions on this one?
no, it's good.
Okay.
And it was you said that there was an amendment. Is that something that?
Yeah, let me just, it's really quick, and then Bryn can explain to you why they're asking for
that
these
would be
changes.
helpful?
So you should have the amendment up there, and I just did it as a recommend, since you don't have possession of the bill, I just wrote it up as kind of like a recommendation from you to Senate Economic Development.
Okay, so I'm looking for it. First, I think we have to refresh. Did you send it in to Alex?
Yep, he has it.
It has been posted.
Okay, so it's the Senate Health and Welfare Recommendations Draft 1.1. No, yes, 1. Oh, yeah, we got it. Okay, thank you.
And the first instance of amendment, this was requested by Dale. That in that section that we just went through, section 954 related to caregivers, is that there's a new subsection added, just a clarification that Medicaid funds are not to be used to support a caregiver in the cultivation and distribution of cannabis on behalf of a patient. It is not current, as far as I know, it's not currently whatever. I think maybe they just wanted a clarification on that. But you could hear from Dale or from Bryn might be able to address that. And then the second instance of amendment is adding a few new sections. This section 14A is just the amendment that I spoke of that would allow the Cannabis Control Board to see see records from the Child Protection Registry. So if they have someone who's applied to be a caregiver, they can check with DCF and say, this caregiver is applying to us, and can you let me know whether or not they're on the registry? The same thing for section 14B, that's the same provision, but related to the vulnerable adult protection registry. So that's on lines 4 and 5. And then section 14C is what I just mentioned about the no rule shall be more restrictive than any rule adopted by DPS. And, you know, one of the reasons of having that is because you might recall that under the previous program that was regulated by the Department of Public Safety, there were not any testing requirements. And, you know, you now have very robust testing requirements among a number of other issues that are currently in statute and in rule regulating these programs. And so they want to take that out.
Okay, thank you. They all seem pretty logical, connected. Questions Committee of Michelle. Ren, you're here. Why don't you come up and introduce yourself for the record and then give us an understanding of what the board is thinking about and going through all this. Doesn't have to be a big, long.
Right. Hello, good morning, committee. For the record, Bryn here, Executive Director of the Cannabis Control Board, and happy to talk through what Michelle just went through with Section 13, and these are the changes to the medical cannabis program, which the Cannabis Control Board oversees. So I think Michelle did an excellent job describing what is being proposed here. I think what I would just like to start out by saying are that the proposed changes to the program are really relatively modest, and all of them are designed to improve access to the program for patients, provide greater flexibility for registered patients and their caregivers, reduce the administrative burden and the financial burden on patients and their caregivers, and also to allow the board, the legislative authority, to really improve the quality of the program by imposing some basic consumer protection standards and some quality control standards that exist in the adult use, the recreational market, but aren't a part of the medical program because of that language that Michelle just went over about no more restrictive rulemaking. So that's the rationale, like as a package for what is being proposed here, but I can go through and talk in more detail about each individual section if you like, and I can go quickly.
Yeah, do that pretty quickly.
Okay,
sure. But we want to get to the proposed amendment so we can decide whether we're going to support it or not.
Sure.
Where is the bill right now?
It's in Senate Economic Development.
Okay, so it hasn't been put up on the floor yet.
Nope.
Okay, so we have a little bit of time.
Yes.
Yeah.
Okay, so the first provision in Section 13 eliminates that requirement for a person who has PTSD, an applicant with PTSD, that they be actively undergoing psychotherapy. And the rationale for that is that really not everybody who's living with PTSD who would benefit from the program has access to a therapist or is ready to engage in therapy or needs psychotherapy. So the idea there is really to sort of expand access to the program for folks with PTSD. The next provision is the increase in the home grow allowance for patients and caregivers. So it allows for 6 mature and 12 immature plants. And that really helps to ensure that patients and their caregivers have year-round access to sufficient quantity and varieties of cannabis. So most of our caregivers are growing outside, and given the climate and the nature of the plant, they're likely to they are lucky really if they get one full harvest. So this gives them the benefit of having a few more plants so that they can grow some additional strains. Some patients benefit from several different varieties of cannabis for the variety of their symptoms. Some strains are beneficial for sleep and some are beneficial for nausea. So it allows them a broader variety, to grow a broader variety for the patients. I'm going to keep jumping along to the next section, which is the provision about background checks for caregivers. So that's starting on page 15. The new language substitutes the requirement for those fingerprint supported FBI background checks with this internal check that the CCB can do, so it sort of reduces the administrative burden for a caregiver to go and get their fingerprints taken. It's kind of a long process. And instead, it just allows the CCB to run its own internal checks of the state registries and the state BCIC criminal history record. The proposal that Michelle just went through in the amendment was a request of AHS to essentially achieve the same thing, but without requiring Dale and DCF to go through rulemaking in order to effectuate that change. So it would really just eliminate the burden on those agencies to carry out the same thing. So I will move on now to the next change, which allows a single caregiver to serve up to 2 patients at a time. So that's the existing language provides that caregivers may only serve 1 patient at a time. So it increases the ability of caregivers to serve 2 patients at a time. And it also authorizes the board to allow additional caregivers if the patient is a minor. And Michelle really described the rationale for that change. If patients are a minor, they may have 2 households. They may benefit from having additional caregivers. And it essentially just vests the board with the authority to, on a case-by-case basis, determine if a minor needs an additional caregiver. So that provides some flexibility to registered patients. The next change is the one that extends the expiration date for a medical card from 1 year to 5 years if you have any qualifying condition except for chronic pain. So all of the qualifying conditions are essentially lifelong conditions except for chronic pain, which of course can be lifelong, but pursuant to the definition in statute, it's pain lasting longer than 12 months. So the idea here, as Michelle did a great job describing, is that rather than requiring these people to go through the process of getting their medical provider to verify that they still have MS, they will only have to do that once every 5 years as opposed to annually. So it really reduces the barriers for patients, both financial barriers and administrative barriers. And lastly is the provision that removes that language that no rule shall be more restrictive. So no rule governing the medical program should be more restrictive than that adopted by DPS. So removing that language will allow the board to require, for example, independent testing of medical cannabis products, require minimum training standards for employees of dispensaries. These are things that we wanted to do initially, but couldn't because of this language. So it really just ensures some basic consumer protection regulations, the same ones that exist in the adult use program and exist in the medical program too. So that's my summary of the medical program changes. Happy to answer any questions.
Terrific, thank you. Questions?
Just curious, couple questions. First time delving into this topic in this committee. So PTSD, who then determines that someone's suffering from PTSD, if not the original language of it?
So they still would have to have a diagnosis of PTSD from that list of medical providers that Michelle provided, which I think is all physicians, physician's assistants, registered nurses, and naturopaths could provide a diagnosis of PTSD. Okay. It just eliminates the requirement that they be an ongoing psychotherapy.
Okay, and then just a comment, just kind of a general comment, being that cannabis is now legal, is the whole program, medical program, even necessary?
Yes, it is, because the medical program provides for a number of benefits that adult use consumers, just your average person, do not receive as a part of the adult use market.
Such as?
Delivery. So patients are allowed to receive deliveries to their homes of their medicines. Delivery is not allowed in the adult use market. The possession caps for patients are different than they are for your average adult. So patients can possess more cannabis at any given time. There's also products that are legal in the medical program that are not legal in the adult use program.
Such as?
High THC concentrates, which are products that patients, especially patients, cancer patients and patients with chronic pain, need access to. So there are some protections and benefits that are built into the medical program that if they were to go away, that would really negatively impact patients.
That's helpful. Thank you.
Thank you. Other questions? And just what we're doing today, looking at some of the recommendations that are coming to us from judiciary and possibly also economic development. This committee has never been fully engaged, except when we first legalized the medical marijuana or cannabis program years ago. This committee really did the heavy lifting on that. And now it's been in judiciary since that time because it is a Schedule I, not legal at the federal level drug. So at this point, we're reaching a level of maturation in the program, and it does make sense for health and welfare to have some oversight on the content of the cannabis that's being distributed and on all of the issues that we're hearing about today. So this is our opportunity to weigh in. We do the proposal of amendment. Were you involved in structuring that? Can you talk a little bit about that as well?
Sure thing. So the proposal of amendment incorporates the requests of Dale, DCF, and essentially AHS to make that, to make that provision, eliminating the requirement that caregivers get fingerprint supported FBI background checks, and instead that the CCB checks the Vermont criminal history record and the vulnerable adult registry and the child protection registry. So for us to be able to do those internal checks, the way that language was originally drafted directed those agencies to promulgate rules that would carry out essentially the policy there. And they have requested that instead of directing them to promulgate rules, instead that we just allow them access in statute, allow the CCB to have access to those records in statute. There are certain individuals and parties that are eligible to receive records, child protection registry records and vulnerable adult registry records. So it would add the CCB to that list of entities that would be eligible to receive those records. So it would just, it's doing the same thing, it's just doing it in a slightly different way, a less onerous way for those agencies.
And then that would mean Elcar doesn't have to go through all the rules.
Exactly, that's right.
That's okay with me.
And the other proposed amendment is just that language that prohibits the board from creating any more burdensome rules exists in two places. It exists in the medical registry chapter, and it also exists in the chapter governing the medical dispensaries. So it's just, we neglected to add the language from the dispensary chapter. So it's just the same language in another place, and it's striking it there also. And the one other thing that I neglected to mention to Michelle that we would request is that the effective date for section 13 would be changed to on passage, just so that these benefits to patients could take effect right away.
So you're asking that we put that into the proposed amendment?
Yes.
Michelle, did you get that?
As opposed to July 1st?
Yes.
I did for all of section 13.
Yeah, for all of section 13. I think unless I hear differently from our committee, we'll be fine with that.
Okay. And then if I could just also add, is I dropped in the chat a link to the statute for medical dispensaries that addresses some of Senator Weeks' questions about, is there still a value to having dispensaries when you have an adult use program? There is legislation, there is statutory language that declares the General Assembly's intent to maintain the medical registry and a system of dispensaries in order to provide those benefits that Bryn talked about. So there is a statutory requirement to continue the medical program despite the addition of the adult use.
Thank you.
Okay, and that's in the underlying bill for medical.
That's in current law.
Right, that's what I'm saying. It's an underlying statute. I said bill, I meant statute.
Correct. Yep.
Yeah, okay, good. All right, questions for Bryn or Michelle? And Michelle, we'll get a clean copy of the proposed amendment. And then the committee can decide how we want to go forward with it. Unless I hear strong opposition, it doesn't sound like it's going to be a problem. You're muted.
I'll add that new one and then I'll send it through editing and I'll get it to Alex.
Thank you. Terrific.
Sure.
Okay.
Not a
Senator.
question.
Yeah.
But a comment. I have a family member who has MS and this program is really, really important to him. So I'm really pleased to see some of these changes. Thank you.
Good. I hope somebody in the family has a green thumb.
That I don't know.
I
It's not me.
know, I know. Okay, committee, any more questions? We're good with this? Thank you.
Thank you.
Thank you, Bryn. It's really great to see you here, right there. Brings back all those memories,
Such good memories.
the good memories, really great memories. And Michelle, you as well. Thank you. All right, so committee, we're finished. We're gonna call this a wrap and we'll come back to that proposal amendment another day. Pretty quick.
I'm sorry that I kept leaving. I was having a coughing fit.
I know, I
was
felt
like-
bad for you.